Okay. Well, thanks so much for joining in, everyone in the school. It looks like we have a great group of people with us to learn and listen and watch from our guest today, Dr. Karla Galaviz. And I'm excited. Karla was going to come in last spring. And unfortunately, COVID changed those plans. But so it's really great that she's been patient with us and rescheduling her talk, and we hope to have her on campus soon. But Karla today has come or is with us from Indiana University. She did her PhD at Queen's University and her postdoctoral fellowship at Emory University. And she's now an assistant professor of applied health science at Indiana University in the School of Public Health. And so what we get to learn from Karla today is research on implementation science and, of course, diabetes prevention interventions in real-world settings, and really having a better, deeper understanding of the effectiveness and uniquely the cost effectiveness of such practices in real-world settings. So I'm so delighted. Thank you so much.
Thank you, Dr. Young, for the introduction, and thank you again for the invitation. I'm really excited to be here, and I see a couple of familiar faces, so that's always nice. I'm going to share my screen now, and let's get started, I guess. Great, can you see it?
Yes.
Excellent. So I want this to be a more dynamic type of presentation. I was just sharing with Catherine before you all joined that I hate speaking to a computer for 40 minutes. It's awkward and people fall asleep, including me. So I just prefer to have a more dynamic type of session. So I'm gonna be opening the mic or chat for questions or comments throughout the presentation. So don't be shy. Hopefully you have some comments or complaints. Those are accepted too. So please don't be shy, and I'll nudge you when those opportunities come. So as Dr. Young mentioned, I'm going to talk about my work actually as a postdoctoral fellow at Emory University, where I spent a lot of time trying to estimate the efficacy and effectiveness of different diabetes prevention interventions. So I'm going to share a part of that work today, as that's sort of the focus of Dr. Young's research, if I understand correctly. So hopefully I'll entertain you for a bit. And before I started, I just want to remind you all about the natural history of diabetes. And the reason why I want to do this is so you can place the interventions that I'm going to discuss on these different phases of diabetes development. So diabetes, or glucose levels, I guess, have these different categories. So a person like you and me can have normal blood glucose levels and have probably or hopefully no issues regarding risk of developing prediabetes and diabetes and complications. So when these, I guess, glucose levels get slightly elevated for different reasons, we can fall in the prediabetes bucket. So that bucket is a risk factor that predisposes people to developing diabetes directly, but also to directly develop microvascular and micro and microvascular complications and death from elevated blood glucose. So even if people do not develop diabetes, just from having these slightly elevated glucose levels that do not reach the type 2 diabetes thresholds, they are increased risk for developing related comorbidities and complications later in their natural history. Now, some of these people will progress to diabetes and develop this disease, which we probably know, and you probably know actually quite well based on your research. It's a very strong risk factor for developing retinopathy, renopathy, nephropathy, et cetera, et cetera. All of these renal and cardiovascular complications that eventually lead to death. So the way we distinguish these different levels of dysglycemia status is with different tests. And we have specifically 3 that are very commonly used. One is hemoglobin A1C. And this one represents the average glucose levels in the blood over the last 3 months. So the cutoff to determine if you or me have prediabetes is 5.7 to 6.5%. So if I go and get this test, and if I'm in 5.9, I can be diagnosed with prediabetes. Similarly, another test we have is fasting blood glucose, which is this one here. I can go to a clinic and get my fasting blood glucose taken, and if it comes with these levels between 100 and 125, I can also be diagnosed with prediabetes. This last one, OGTT, stands for oral glucose tolerance test, and that is a test that actually focuses on determining the tolerance you have to glucose after you eat, or in this case, after you drink a bottle of glucose juice that tastes disgustingly, in order to see how your glucose metabolism works out. So if after drinking this, or 2 hours after drinking that disgusting bottle, you have levels between 140 and 149, you can also be diagnosed with prediabetes. The same tests are applied for type 2 diabetes, but with different thresholds. Anything above what I just mentioned is considered to be diabetes. So a lot of people, like I mentioned, can just be in this pre-diabetes range and still experience a lot of the cardiometabolic complications related to type 2 diabetes without actually progressing to diabetes. That is why a lot of work has focused on this group here, people with prediabetes, not only to prevent them from progressing to diabetes, but also to reduce the risk for cardiometabolic complications down in the road. So these primary prevention efforts are focused on preventing these people from progressing to overt or frank diabetes, but also to reduce the risk, as I mentioned, for complications later in the natural history. Now, a lot of the work that I understand Dr. Jung conducts is also focused on secondary prevention in people with prediabetes. So as you can see here, those who have type 2 diabetes have an increased risk or very elevated risk for developing cardiometabolic complications and dying from these complications. So a lot of work is also focused on reducing the risk of these complications, mainly through lifestyle modification, including physical activity, diet, smoking cessation, and primarily through medications as well. I think about, if I recall correctly, 50 to 60% in the US with type 2 diabetes actually just manage very well with lifestyle modification. I think the other 25 to 30% requires medications, and less than 5% actually ends up requiring insulin to reduce or to control their glucose levels and avoid developing cardiovascular complications. And of course, there is also the tertiary prevention realm, which is people who already develop complications. How do we help them not becoming worse and potentially dying from these complications? But I do not work in that area at all. And actually, most of the work I'm focused on, and the data I'm going to show you today, is focused on this bucket here, the primary prevention of type 2 diabetes. So far, so good. Any questions or comments? And it's okay, don't feel pressure. And we just started, we're just warming up. But this slide has a lot of information shown, so I just want to check with you. I see there's one thing in the chat, but oh, that's Jeremy. Hi, Jeremy. He's just saying that. Awesome. Okay, I'm going to move on. Another thing I want to point out that is related to the data I'm going to show is that there is heterogeneity in the types of type 2 diabetes. And this is hypothesis that one of my mentors at Emory University proposed back in 2016 that talks about two different types of type 2 diabetes. And this hypothesis is based on data we obtained, or my colleagues obtained, in studying prevention and pathophysiology of type 2 diabetes. So he found that, and he's proposing that there is a type 2A diabetes, which is the one we are all familiar with, that is characterized primarily by a problem of insulin action or resistance to insulin or decreased insulin sensitivity. So this has to be with the uptake of insulin in your muscles. So the type 2A diabetes is characterized primarily by this problem, insulin sensitivity, by that is potentially caused by adiposity, physical inactivity, poor diets, etc. Like I said, the type 2 diabetes we are all familiar with. The best way to diagnose this is with the 2-hour oral glucose tolerance test I just mentioned. And also the best ways to treat this is with lifestyle modification and metformin. And the group that is more specific or characteristics of this type of diabetes is Pima Indians that have been widely studied here in the US and Mexico, and they all share these characteristics. Now, our data from actually South Asia is showing that there is potentially another type of type 2 diabetes, which is the type 2B one, that is characterized primarily by a problem of insulin secretion. So this is the beta cell function. They are not properly secreting insulin as needed. The causes are unknown, but some academics, some researchers, some colleagues have proposed that it can be poor maternal and child nutrition or undernutrition, low birth weight, reduced beta cell mass related to different causes that I actually I'm not an expert on, lipotoxicity, endocrine disruption. There is also the way to identify this type of type 2 diabetes is with the fasting glucose or with 30-minute glucose tolerance test. So similar to the 2-hour tolerance test, you would take this glucose use, but instead of waiting 2 hours, we'll look at your glucose at 30 minutes, and actually also at 1 hour, 90 minutes, and then 2 hours, and see how it looks. The initial treatment, again, we don't know. That's why this is full with question marks. Could be lifestyle modification, maybe insulin secretagogues to improve beta cell function, insulin, and the classic ethnic group that this diabetes type is characteristic is the Asian Indians, South Asian Indians. So like I said, this was in 2016. Since then, a lot of the data that my colleagues have collected and some of the data I'm going to show you now are suggesting that this is a hypothesis that actually has a strong evidence backing it up. So just bear this in mind. I'm going to move to the next slide. And this presentation is going to be focused on prediabetes, on how we manage prediabetes, both ways. How do we help people not progress to diabetes, and how we help them maybe reverse to normal? So just on their own, people with prediabetes, about 17 to 42% of them will revert to normal. This is if they do nothing, if they don't change their lifestyles, if they don't take medications, a bunch of them is going to revert to normal. But as you can see, about half or over half of these people will remain in the prediabetes stage. And as I mentioned, just having prediabetes is a very strong risk factor for cardiometabolic complications and death. Now, 5 to 10% of these individuals will progress to diabetes within the next year of having developed dysglycemia. So that is why a lot of the diabetes prevention interventions that are being tested are focused on this group here, the pre-diabetes folks. As I mentioned, interventions have included mainly lifestyle modification, but also medications, Chinese medicine, some herbal alternatives, dietary supplements, a bunch of things that I'm going to tell you a little bit about later. Actually, this is a very good example. I forgot this was here. So from the interventions we know, that work in people with prediabetes are mainly lifestyle modification. This is improving physical activity and improving diet, mainly reducing sugar or glucose, simple glucose consumption, and reducing fat consumption. So these type of interventions reduce the risk for developing diabetes by 39%. There are also some medications that have been tested, as I mentioned, mainly metformin and other insulin sensitizers. So these medications have been shown to reduce the risk for developing diabetes for about 36%. And finally, there is also evidence that vitamins, vitamin D specifically, can reduce the, or dietary supplements, but mainly vitamin D actually, can reduce the risk of diabetes by 32%. So these are estimates that are all come from meta-analysis. Now, there is also the other side of the coin. So now we were focusing on how do we stop people with prediabetes from developing diabetes? And we're rightly focusing on that. But more recently, and this mainly through the diabetes prevention program, we found people with diabetes can also reverse. And if they reverse, they reduce the risk for developing cardiovascular complications. So now there is a lot of work also focused on the other side of the coin, which is, can we revert prediabetes? Lifestyle modification have shown that yes, it can be, it can reverse prediabetes in about 53% of the participants that receive that intervention. Same with some medications. Meta-analysis have found that there are double the odds of regressing to normal glucose levels if those medications are taken. And there is also evidence from dietary supplements that promotes or that helps people revert to normal in about 41% of participants. So like I mentioned, these are all estimates that come from meta-analysis that have been conducted separately. So far, or up to the point where we decided to embark on this work, no meta-analysis had compared the effectiveness and efficacy of these treatments against each other. So that's sort of the goal of this work, and this is the data that I'm gonna share with you today. So the objective of this research that I'm sharing was to pretty much estimate those efficacy and effectiveness data points for any diabetes prevention intervention that was not surgery. And we were interested in the efficacy versus effectiveness question because, as you know, the efficacy estimates are usually higher, or they inflate the impact of an intervention because the way they are tested is very highly controlled and probably among heterogeneous samples that are highly motivated. So we wanted to see, okay, let's see the most internally valid estimate to obtain the largest effect potentially achievable with these interventions. But let's also look at the real world and how does this estimate look like when implemented in real world conditions. Before I move on, are there any questions or comments about what we have discussed? And like I said, there's a lot of information that I just threw. So any question or comment is welcome.
Karla, I actually just sent a chat message. On the previous slide, those percentages,
Mm-hmm.
was that over a year? Like, I'm surprised that so many people move in the positive direction versus the negative.
That's a very good question, and I should have put the follow-up times here. I don't remember the exact follow-up times, Chris, but it's for sure after 1 year at least. For medications, I think, if I recall correctly, the average was about 3 years. I don't remember for the others, but you're absolutely right. The time at which they measure this matter, and I'm going to show that in our data. And not only that, but if they stop, for example, the physical activity intervention, or if they stop the medication, that also impacts these percentages, these effect sizes, and I'm going to show that. But you're absolutely right. We should pay attention to those follow-up times, which I did not, so I apologize. But especially actually for reversion rates, you're absolutely right. It should be something to consider.
Oh, that's great. Thanks. I was just surprised that the numbers looked so good.
Yeah, they do. And these are all, of course, randomized controlled trials, highly controlled. And this is the estimate at the end of the intervention. Like I said, of course, there is a loss in this huge effect size after people stop taking or engaging in the intervention. But thank you for that comment. Absolutely right. Excellent. Any other comment or question? I like this. Good. And please interrupt me, even if I'm not opening the floor or opening the mic. Just put it in the chat and interrupt me. I think that's way better than just me talking. Thank you for that, Chris. Okay, I'm going to move on. So in order to answer these questions, we conducted 3 systematic reviews. So much fun, not, of course. 3 systematic reviews, and I'm actually in my 4th right now. I don't know why. Don't do it. Don't do it. So the data that I'm going to show you comes from 3 systematic reviews, and we checked different databases. We were looking for studies that were testing different interventions, different study designs, and I'll give you more details when I'm talking about each of these systematic reviews and meta-analysis. And we were interested in those 2 sides of the coin, right? To what extent do these interventions prevent people from developing diabetes, and to what extent can they reverse prediabetes? And then we used random effect meta-analysis to obtain these pooled effects and mainly estimate relative risks and absolute risks for either developing diabetes or reversing prediabetes. So I'm going to start with the first, actually before that. These 3 meta-analyses actually identified 133 papers from 19 countries. These 3 systematic reviews were conducted separately because we had different research questions for each, and we had different search terms for each. But I wanted to show you that together, we actually got a bunch of studies that was a pain to extract and to analyze. But at the end, we were very happy with the product. And something that we like about this map, and the numbers are the number of studies that we found in each of those countries, is that you can see where the evidence is coming from and where the gaps are, right? So, for example, at the time of the review, which was, I think, 2016 and 2017, you could see here that there were no studies coming from South America. So that's something that we were actually recommending, that we need to expand the evidence base and hopefully, or maybe, you know what, maybe it's because we didn't search in Portuguese, but we did search in Spanish, we did search in English, we did search in Chinese. Luckily, our team was fluent in those languages, but it's important to know the limitations of where the evidence we are using to make policies is coming from. And something also surprising was that at that time, we only found 4 studies conducted in Canada. So lots of work to do up there. So this is the first meta-analysis. And this one was focused on 2 things. Number one, what is the efficacy of different diabetes prevention interventions for reducing diabetes incidence? So to what extent can we reduce diabetes incidence in people with prediabetes, in people in that bucket? That was number one. And number two, we wanted to know to what extent can the beneficial preventive effect be sustained after people stop their intervention. So here we looked at interventions that tested medications and lifestyle modification strategies mainly. We only included randomized control trials because we were focused on efficacy of these interventions. And we identified 53 studies after our very, very painful review and screening process. I'm sorry, I keep complaining about this. I should be more positive. After our brilliant review and screening process. So we conducted a pairwise random effects meta-analysis. And by pairwise, it means we mainly compare intervention versus control in each of the different treatments we identified. This table shows a bunch of things, but the coolest thing for me is here, the risk difference, or the difference in the absolute risk. And these percentages are telling you that 50% of people that received a lifestyle modification intervention developed diabetes versus 25% of people in the control group. This yields a risk difference of 10%. And if we divide 1 over this 10%, we get the number needed to treat, which is 10. And what this means is that in order for one person to not develop diabetes, or in order to prevent diabetes in one person, we need to give the intervention to 10 people. So this is what I mean and what it means, and it's closely linked to the cost effectiveness point that Dr. Young made, though we didn't look at cost data, so we cannot actually estimate cost effectiveness. But if you compare that number needed to treat versus medication, that's 25 people here. So in order for one person with prediabetes to be prevented from moving to diabetes, you need to treat these persons, you need to treat 25 people with these medications. There is also the diabetes incidence here, the rates per 100 persons per year. So in 100 persons in 1 year, 7.4 people develop diabetes in the lifestyle modification arm versus 11 in the control arm. And you can see the rates were quite lower actually in the medication arms. But this is something that we wanted to see, okay, is it that the medication is more effective, or what happens after a longer follow-up period, or what happens when people stop taking the medication, and what happens when people stop engaging in the lifestyle modification intervention. So that's the second question and we wanted to address. And maybe, Chris, this is related to your comment. Here, we only looked at studies. So this is a subgroup analysis of studies that reported diabetes incidence rates, or the number of people that developed diabetes after the intervention was stopped, after people stopped engaging in the intervention. So there were four studies testing lifestyle modification interventions that reported what happened to diabetes incidence 5 years, 5.7 years, 9 years, and 9.4 years after people finished with the intervention. And as you can see here, people still, even up to 9 years after having received the lifestyle modification intervention, had a 28% lower relative risk for developing diabetes, 28%. We did the same thing for medication arms. As you can see here, everything is in weeks. This is what it's called the washout period. So after, in a clinical trial, participants receive the drug that is being tested, then it's very common that researchers help people come out of the medication and give them a couple of weeks, for example, here 10 weeks, 12 weeks, 2 weeks, to be off the medication. And then they check at the outcome again to see if the medication still has an effect. So we were able to look at different studies testing those medications here, mainly insulin sensitizers. One was insulin. And you can see that the relative risk reduction after people was off the medication was 5%. And not only that, but as you can see in the confidence interval, in some studies, the risk of diabetes was actually higher. In some studies was lower. So we could not be as confident as we are with with the effect size of lifestyle modification, then has all of the effect sizes indicating reduced diabetes risk. So this means that lifestyle modification is better in the long run than drugs for diabetes prevention. Now, before I move to the next meta-analysis, before I move to the next meta-analysis, one more thing. Recall the different or heterogeneity of type 2 diabetes. Remember, type 2A is the one we are familiar with, and type 2B is the one that we are starting to learn that it looks more prevalent in Asian Indians, South Asian Indians, sorry. So we did a subgroup analysis here and wanted to see what happens in people that have just a problem with fasting glucose, when their fasting glucose levels are impaired, but their after eating glucose is normal. What happens to those? So as you can see here, there is no effect of the interventions. And this is a medication, this is a medication. Oh, this medication this is probably an insulin secretagogue. And I'm probably not saying that right. And this is a lifestyle modification study. See, nothing, even actually maybe increased risk. But it seems like these interventions are not working in people whose primary problem is the secretion of insulin. And this is the group of people that we are familiar with, those whose problem is insulin sensitivity or tolerance to glucose. And we found that, well, it doesn't seem to be a beneficial effect of at least these interventions in people with the phenotype that we are just beginning to learn from. Yes, Chris.
Yeah, sorry, I'm.
No, please.
This one isn't me. It's not just me being disruptive. I'm relaying a question on behalf of someone else. So they were wondering if the participants in the lifestyle studies were similar or matched to those in the medication trials. I mean, obviously they're different studies, but did anyone try to compare the two groups?
We did not compare them per se, but we did look at their demographic characteristics, prediabetes. They were pretty similar in terms of age, sex, and race, and they all had prediabetes. So very good point, very, very good point. Usually the participants that enroll in this type of medication trials tend to be higher risk, more heterogeneous type of groups. So that's why we actually looked at it. It should be somewhere in the supplement files of the article. Very good point.
Thanks.
Great, I like this. What else? Okay, I'm gonna move on. So this was the efficacy meta-analysis. Have in mind, these interventions are being tested under highly controlled conditions. These are all randomized controlled trials. That's why effect sizes are quite large. Now we wanted to see, okay, now looks like, lifestyle modification is the best way to go according to our table. Let's ditch medications. They have a lot of side effects. They are more costly. Their effects wash out over time. So let's look at lifestyle modification and see if the effects are positive, negative, small, large, when these interventions are tested in the real world. So that's the second meta-analysis I'm going to show today. And for this, we identified not about exactly 63 studies, but here we included studies testing lifestyle interventions that employed any study design. So this could be randomized controlled trials, pre-post studies, quasi-experiments, time series quasi-experiments, as long as they had a control condition or a comparison group, like a pre-post study. So anything. And we also made an effort to make sure that they were testing effectiveness, because we had some randomized controlled trials, but they were conducted under real world conditions. And that were specifically testing effectiveness. So that's how we identified these 63 studies. And here, because they are not randomized control trials, or all of them are not, we decided to do an arm-based network meta-analysis. So what we did is we grouped all the different interventions that were tested into these buckets. And then we grouped all of the control groups into a bucket. And then we compared all of the interventions that were tested against that control bucket. And this something that related to the question that Chris read out loud. We also looked at the characteristics of these participants that we sort of like put together in these buckets against control. And we thought this was going to be a mess because here the participants we included were only at high risk of diabetes. So some of them had pre-diabetes based on the different diagnostic tests I mentioned, or some of them that were only considered to be a high risk, either based on a risk score or the demographic profile, etc. So we did look at the demographic characteristics and they were pretty balanced, to our huge surprise. So just pointing that out for that person who made that brilliant question, by the way. So this is how we put them together. So the large N is the number of arms that we put in that bucket. So for example, for group education offered by a healthcare professional, and remember this is for diabetes prevention, so this is mainly lifestyle modification. There were 31 arms that we took from these studies, and in total, those arms included 8,000 people that received that intervention. So you can see the rest of the numbers in the other buckets or interventions that we tested. And here's what we found. What do you think was the most effective? What do you think? For preventing diabetes. So this is from stopping people from developing diabetes. What do you think was the most effective? Chat it, put it in the chat. I want to see. Which one do you vote for? Which one do you vote for? I'm gonna give a chocolate. Mail it. Individual counseling, individual counseling, individual counseling. Okay, okay. Of course. Community member, huh? We have an outlier here. Okay, 2. Okay, Kathleen, you're recruiting more supporters. Group education, but develop the community. Okay, peer support. This is fantastic. To my surprise, it was group education offered by a healthcare professional. But those of you voting for the community group education, you were actually pretty close too, because we saw the lower odds from developing diabetes, about 29 lower odds, but our estimate included the null, right? So in some studies we had no null effects, and some studies we had positive effects. But we attribute this to mainly sample sizes and precision of our estimate. As you can see here in the community group education, we have only 418 participants and 4 arms that contributed to this estimate, versus 11 arms and over 5,000 participants that contributed to this arm. So I'm with you, because in another meta-analysis we completed, we found that there were no difference actually in effect sizes when the intervention was delivered by a community member versus the intervention being delivered by a healthcare professional. No difference. So we sort of thought we were going to have a similar finding here, which again, if you look at the effect estimate, it's somewhat close. It's pretty close. So something that we actually discuss is that this is for diabetes incidence, right? For that outcome. So in order to measure whether or not you have diabetes, you need what? Glucose testing. And for glucose testing, it's usually better to do it in the clinic. Though some studies have done it in the community, as we can see here, we have 4 arms, and actually these correspond to 4 studies to be exact. So again, just be aware that the sample size has a lot to say here in terms of opening the confidence intervals for the estimate. So I'm still a huge believer on community-based and community member delivered intervention. So I'm so glad some of you brought it up. But yeah, this was not surprising. Like I said, larger sample size, clinic has the resources to test diabetes. And a bunch of studies did not test for diabetes incidence. So I think this is just 1, 2, Less than 15, 16 studies out of the 63 we included reported this outcome. So the outcome, remember, these are real world studies. So the outcome that was mostly tested or most consistently reported across the studies was weight change. Weight change. Look at the ends here, 26 studies, 30 studies, 3 studies, 8 studies, compared to what we had in the previous slide. So weight change, we saw a very good difference by the community member here, a reduction of 2 kilos, even if the intervention is being delivered by a community member. And we saw no effect on fasting blood glucose. Again, who knows, maybe sample size or I don't know, or maybe something that doesn't make sense. But we attributed this to the number of people in this for this outcome in fasting blood glucose. But look, weight change didn't seem to be very, or it was at least half of what it was for the community member. Individual counseling and education via technology don't seem to be very effective. Something very surprising too, based on what we know from efficacy studies. But we were very interested in the weight loss effect here, because 2 kilos is huge. And like I think I didn't put the follow-up times here, but here were interventions that lasted 12 months to 2 years. So it's important to look at what happens to weight change at the end of the intervention. And also, we wanted to see, does losing weight matter, and to what extent it matters. So then we did a meta-regression just to see how do weight loss associate with the odds of developing diabetes. And we saw that for every kilogram that a participant lost, this associated with 33% lower odds of developing diabetes. So the greater the weight loss, the better, or the lower the diabetes risk. And something that was really amazing for us to see here is for every additional kilo, so that's 1 kilogram, the mean weight for these participants was, well, I'm gonna give you the range. I think it was like 85 to 95 kilos. They were people with obesity, people with overweight. And the diabetes prevention program here in the US, which is the gold standard that all of these programs are actually based on, all of these studies that I'm sharing with you are based on, to be reimbursed by Medicare here or the government healthcare insurance, has to show that the program that can be offered by community organizations have to show that people lose 5% of the body weight, which in our sample, it could be up to 5 kilos, right? So Medicare does not pay, for example, the YMCA, if they offer the diabetes prevention program, unless their participants lose 5% of the body weight, which is ridiculous, because the YMCA is taking the risk of training their staff to deliver the diabetes prevention program. They are covering all of the expenses to have people come, measure the weight, do the classes, etc. And Medicare won't pay them unless people lose 5% of the weight. So something we did here, or with this data, is we organized a meeting with a bunch of payers of the diabetes prevention programs, included Medicare or CMS. And we tried to persuade them with this data, say, hey, look, it's good that you're focused on weight loss, absolutely. It's a huge driver of diabetes risk, but maybe you want to be more flexible with the threshold you are putting to the community organizations that are offering these programs, right? So they didn't care. We tried to say 1 kilo, 2 kilo. Why don't you say 2 to 4% or 2 to 3%? But no, it didn't work, of course. But this is one of the main findings that we were very excited about for this study. It's 7:15. I will rush for the remaining of the presentation, but I want to know if there are questions or comments now. Are you still awake? That's one very important question that I have for you. Okay. I'm going to move to the third meta-analysis. Are you sure you don't have a question about this one? Oh, I see a chat. Oh, your babies are asleep?
They stayed on for the beginning of your presentation, Karla, but they fell asleep during the middle, not because you're boring, just because they're
I would be very glad if I can help you put your babies to sleep. I would be very happy that I can help you that way.
Presentation, so you keep going.
Yeah. Thank you for that. Great. I'm gonna move to the third. Okay, I have a question from Paula. What was with the additional kilogram loss versus the 1-2? So if I understand your question, you mean why we care about saying 1 kilo versus 1 to 2 kilos, or percentage of body weight? Maybe I need some help to better understand. You mean the percentage versus the kilos?
Hi, can you hear me?
Yes.
Oh, hi, sorry. I don't know if I was listening properly, but I thought you were saying something about like you were saying something about 1 to 2 kilograms of weight loss, but then you also said something about like additional body weight. That was also like additional kilograms that they lost or something.
Oh, okay.
I could be wrong about that.
No, thank you, Paula. I think I probably misspoke and I probably didn't say it clearly. What I mean is that if people lose at least 1 kilo as part of the intervention, that significantly impacts or lowers their risk for diabetes, just 1 kilo. But if for every additional kilo they lose, their diabetes risk goes down further. So what I'm saying is we just wanted to bring attention to the fact that even 1 kilo, which corresponds to 1% of your total body weight, can have a huge impact on your risk for diabetes. That's what I meant. Thank you for
okay. And then if you lost like 3 kilograms, you would have a like after the one the risk goes like drops even more. Is that
exactly.
Oh, okay, perfect. Okay, thank you very much.
You're welcome. I don't know how much more, because then we would need to do a different type of the analysis, because this is just for every kilo. This is the 43% lower odds. But what this graph is telling you is the more weight you lose, it's the lower your diabetes risk. And yes, it is probably cumulative, but probably not as impactful or as large as an effect size to the effect size or the benefit you get with the first kilo, with that first chunk, right? Same as with physical activity. Very good question. Thank you, Paula. Paula. I said Paula. Okay, I'm going to move on so I can just tell you a little bit about this third meta-analysis. This has not been published. This is actually currently under review. And this meta-analysis is focused on looking on diabetes reversion. So, sorry, pre-diabetes reversion. So we wanted to see if people with pre-diabetes can go back to normal with a bunch of different interventions. So here we were focused on efficacy, and we wanted to look at, or we included randomized controlled trials that tested any intervention and that reported the percentage or the number of people in their study that had prediabetes and at the end went back to normal. And then we just did similar to what I showed you just before, an arm-based network meta-analysis. Now I'll tell you more of it in the next slide. So this is how the network looks like. We identified 47 studies that were reporting this data. And as you can see here, unlike the previous meta-analysis I showed you, we not only are comparing the interventions against control groups, but we are also comparing all interventions and medications against each other. So here, the thickness of the line indicates the number of arms that are directly comparing those two treatments. And the size of the bubble refers to the number of participants in that bucket, in that group. So as you can see, most of the evidence we have is for lifestyle modification against control arms. And the second largest treatment that has been tested for reversing prediabetes is insulin sensitizers versus control, and also versus lifestyle modification. So the purpose of this figure is to show you where the evidence is at and where the evidence is lacking. So we pulled all of these studies together. We obtained the relative risks, the risk difference, and the number needed to treat that I explained in previous slides. So what I want you to take from this slide is three things: alpha glucosidase inhibitors, herbal alternatives, which are mainly Chinese medicine in this meta-analysis, insulin sensitizers, and lifestyle modification studies, and also weight loss medication, all promote higher reversion rates to normal glucose regulation. And you can look at the effect sizes here. The largest is for weight loss medication, but it's also the most, or the least precise estimate. This is just one study. That's why we see a very small square here and a very long confidence interval. I wouldn't trust that estimate as much as look at the lifestyle modification. Humongous, amazing effect. I'm sorry, I just love this square here. I'm also biased for lifestyle modification, but I try not to. But it's the most precise, and even though the effect size is not as large, it's just the relative risk 90% higher. But still, with 6 people that receive the intervention, you get 1 to reverse to normal. And the other one is, this one is smaller for this medication and Chinese medicine. This is sort of like a mystery for us. We're still working through that to understand the mechanism through which Chinese medicine promotes improvements in glucose regulation. Now, we also compare treatments against each other. As I said, these estimates you are seeing in the plot are intervention versus control. And you can see just from eyeballing this that no intervention is better than the other because all the confidence intervals overlap. But we also tested this empirically through analysis, and we just confirmed what we saw in the first plot. Now, go back to the type 2A versus type 2E diabetes. We also looked at what happens in people whose primary problem is impaired fasting glucose, meaning beta cell function or insulin secretion, insulin production, versus people whose primary problem is insulin action or use or sensitivity. We found the same thing we found in the previous meta-analysis, that in that lifestyle modification, but also medications don't seem to have a beneficial effect in people with impaired fasting glucose or with beta cell function problems. So this further supports that hypothesis we have that there may be heterogeneity, or there is heterogeneity in the types of type 2 diabetes. And these different phenotypes we are seeing here, in this case of prediabetes, may require different interventions, because clearly what we're doing is working for one phenotype, that is people whose primary problem is insulin action, but it's not working for other groups. I also highlighted here that interventions were more effective in people with comorbidities, not surprisingly. And for this meta-analysis, we also assess the strength of the evidence, meaning what is the risk of bias in these studies? Are there publication bias? Is there a bunch of things that we assess based on these recommendations? And we found that, and the number here in the bubble is the number of studies that were put in that category. We found that lifestyle modification provides the strongest evidence of efficacy for reversing prediabetes. So what did we learn from all of this? 3 main things. Number 1, I think lifestyle modification is maybe the preferred intervention, both for preventing diabetes and for reversing prediabetes. Just bear in mind, at least in the US, there is no medication approved by the FDA for preventing diabetes. all of the medications that we tested and those clinical trials have tested were developed for treating diabetes or treating other things. So they are just pretty much experimental, if you will, at this stage. We also found that weight loss is a prominent driver of diabetes risk, but we don't need the amount, the 5% that in this case our healthcare insurers require here to achieve a significant reduction in risk. And number 3, we still don't know what works for people with isolated impaired fasting glucose. So we may need to explore other interventions for those folks. And just want to close by saying that the guidelines here, diabetes clinical guidelines, have identified lifestyle modification as a first-line approach for both preventing diabetes and reversing prediabetes. So we just pretty much align with those recommendations. And this is the amazing team that helped with all of this work and the funding I was lucky to receive. So thank you for that. I think we have some time for a couple of questions. You are all muted.
That was fantastic, Karla. I'll jump in, and I don't know if Chris will kick me off or Catherine, who are the real bosses here. But I just want to say a personal thank you, and I'll follow up with questions I have, and I'll shut up. There's lots of questions in the chat room. Karla, are you able to read those, or did you? Yeah, okay.
But it's more fun if you read them for me.
All right. Well, Dr. Eves from UBC Okanagan asks if it is just weight loss that is important, or is it changes in the type of fat, so visceral versus subcutaneously? So maybe start there, and then I'll ask.
Very good question. We did not look at where the body fat was, which we all know that probably a visceral fat, or not probably, we all know the visceral fat has a stronger effect upon glucose regulation, metabolism, dysregulation too. So it would be actually, we have that data. We could probably look at it with waist circumference, I believe. But we did not look at that. I could not answer your question, but definitely would make an uneducated guess that it's probably visceral fat, what we saw driving the risk. Mm-hmm. Let me, what's the second part? Like, did you look at which specific were for glucose regulation?
And I think he means, probably means, obviously this is a meta-analysis. So did the interventions that were included in the meta-analyses look at glucose regulation?
Mm-hmm. Absolutely. No, not directly, in the sense that these interventions that was not the main outcome of the interventions that we included or the studies we included. The outcome was either diabetes incidence or prediabetes reversion. But we did look at it indirectly in terms of looking at fasting blood glucose and oral glucose. And of course, impaired fasting glucose is one thing, and glucose tolerance is another thing. But at least by looking at those outcomes, we could see if lifestyle interventions or medications or even herbal alternatives had an impact on those precursors of diabetes. So I would say that actually that was the main goal in this second meta-analysis, to look at glucose regulation, whether or not people can go back to normal, because in prediabetes, glucose regulation is impaired.
Thanks, Karla. Can you see that second question coming up from Femke? Within lifestyle modification interventions, have you looked into differences between single versus multiple lifestyle interventions?
Very, very good question. Yes, in the first one, in the first efficacy meta-analysis, we looked at physical activity versus physical activity plus diet versus diet alone. And we found that physical activity alone did not do as good as a job as when combined with diet or diet alone. And we believe because in people with obesity, in people with overweight or obesity, weight loss is a main driver. But as I showed you in my data, people without obesity or people with other problems don't benefit from lifestyle modification or weight loss. So in people with obesity, it made sense that combined physical activity or diet were the most effective approaches versus physical activity alone. We have not looked at different behavior change techniques, for example, which Dr. Gainford has. She has an amazing paper comparing, an amazing meta-analysis comparing the effectiveness of not only diet versus physical activity versus both, but also which behavior change techniques are the most effective. And I believe it's in people with diabetes, but she of course knows that work better. And yes, there are some techniques that have been found to be more effective in people with diabetes. But yeah, short answer, yes, we looked at it. Diabetes, physical activity plus diet was the winner. And I don't see any other questions.
That's fantastic. You're clearly engaging, Karla. We're kind of moving past the hour and people are still engaged. Maybe I'll leave it up for any other final questions before we let you off the hook here.
Thank you. I may be stealing their social time.
Karla, it's Heather here. I'm not going on video because it's the first time I've ever watched a talk from a playmat. I wanted, one, to thank you for your presentation and for being so engaging. But also I wanted to ask you, because I know there's a lot of graduate students on the call, and I had the pleasure of doing graduate school with you. And so I'm wondering, advice you have for graduate students post-graduate school, because you are doing work that definitely complements what you did in your PhD, but has really extended it. And if you have some key pieces of advice that might support graduate students going forward.
Wow. One thing comes to mind. Thank you for that question, Heather. Thank you so much. One thing that was really like a super, because I knew zero epidemiology, zero. My training was in health intervention research, zero epidemiology. So for my postdoc or for additional training opportunities or work, I always try to get out of my comfort zone and learn something new and something completely like, no, I would no, it doesn't make sense that I go do that. And that's exactly what I did for my postdoc. I just moved to a different country and went and did diabetes epidemiology. And I thought I was not going to be able to be functional or do something productive. And I learned so much. And it's just great to get out of your comfort zone and learn something new, even if it doesn't make sense. Like computer science right now, that's what I'm learning. Computer science. It's always something that opens, I guess, not only your perspective, but your field. So your maybe job market, your skill set, so you can be more competitive and more diverse in your skill set. Another example is during my postdoc, my mentor said, hey, do you want to do research in HIV? And I was like, holy cow, no, I know nothing about HIV. And he said, read this paper. It's about diabetes in people with HIV. And I read it. I was like, whoa, this is so interesting. I'm going to do it. I know nothing about HIV. I right now have a grant from NIH funding my research to look at cardiovascular disease in people with HIV with computer science. So never thought I was going to be doing something like that. So just get out of your comfort zone, try new things. If it works, great. If it doesn't work, great as well. You are going to get something out of it, because I'm giving you the examples that things that worked, but I have very many examples of things that did not work. But those were useful too, because I learned, okay, I'm not good for that. okay, maybe I should not go that far, but at least I tried and now I know. So get out of your comfort zone, learn, get every opportunity, even if it's completely out of your area.
Thanks so much.
You're welcome.
Anyone have any other questions about the diabetes research? Or components like that? If not, I've had a couple private messages that just wanted to say thank you, Dr. Galaviz, for your fantastic and informative talk. There's also a plug for you really sold the idea of systematic and meta-analysis reviews to the graduate students who I'm encouraging to take my class in January. So thank you. Don't tell them how much work it is, tell them how much fun it is. But no, I really want to thank you for your informative talk. We're gonna have to do a separate lab meeting on your work next week. And we'll end it there. Please join me in a virtual round of applause for Dr. Galaviz, and thank you again for coming.
Thank you, happy to be here. Thank you for having me. Nice to see you all. Have a good